guys, welcome back to my channel. Today we're going to be talking about statin drugs because these are very prevalent drugs today. There's about 35 million Americans on this medication currently. So I think it's really good for the patients that are on this or patients that may be put on this in the future to know about the things that we're going to talk about today. So today I decided to bring on a special guest, my sister, Heather Smith.
Hello.
She's a medical student who has also been working in the primary care field for a while now. And I thought that this would be important to bring on for this video because she gives a unique perspective from the prescribing side instead of just the pharmacologic side like I see. So let's get started. So statins are used to decrease the cholesterol in our body, and they do this by blocking the HMG-CoA reductase enzyme. Now, there's a long pathway as to how this happens, and I just don't think that that's very beneficial for y'all to know. So, let's just go into why this drug is prescribed so often and why it works so well. So, I was just talking to them about how often statins are prescribed. Can you tell me about, on a day-to-day basis, how many y'all prescribe?
Yes, so our office is located in a rural town in South Georgia, and I do think that every doctor's office is unique in its population, and that does play a part in how often things are prescribed. In the South, we eat a lot of junk food, a lot of fried food, greasy food, things that lead to high cholesterol. So I would say we prescribe statins in a given day. We may see 24 patients, and out of those 24 patients, probably 22 of them are on a statin. Now, that might not be prescribing a statin that day, but they're either on it as a maintenance med or we're starting it. A good 85 to 90% of our patients are on statins at this moment.
The main thing that we worry about with high cholesterol is atherosclerosis. That is the deposition of fatty material in the artery walls. Now, we're worried about this because this can lead to strokes, heart attacks, heart failure, and things of that nature. So what we want to do is get the cholesterol in the body to stay under these certain numbers that we look for on labs when you get your blood work done. And if we keep these cholesterol numbers under these certain levels, we can decrease the risk of these things happening in our patients. So I told them about cholesterol being high and why that's so dangerous in the body. I did not go into the numbers that they would look for on a blood test when they get that drawn. Can you go into the numbers that you look for? Maybe what's that next step after that, after you see that they're high?
Sure. So in general, primary care providers throughout the country strive for a total cholesterol of less than 200. Now, if you have any other comorbidities such as diabetes or some form of cardiovascular disease, we want that to be a lot lower because you're already at a higher risk for developing plaque, the atherosclerosis that she was talking about, on those artery walls than other people. So a good general guideline is for someone who doesn't have any other problems except for the high cholesterol. We say 200 total with an LDL or bad cholesterol of less than 100, and an HDL or a good cholesterol, we want that to be above 40, and the closer we can get it to 50, the better. If you do have diabetes or if you do have cardiovascular disease, we'd like that total cholesterol to be a lot closer to 150 and even lower than that if we can, the total cholesterol. As low as we can get that LDL, we like it as low as possible. So, I mean, some people, they're not going to get it much under 100, but the lower we can get it, the better.
Statins are first-line treatment for decreasing the cholesterol in the body because they work very well, they're pretty cheap, and they're pretty well tolerated. The main side effect that people taking this medication are going to notice is maybe some muscle soreness or muscle pain. It occurs in about 10% of patients on the medication, and it'll usually begin within a couple weeks to months of them starting it. Now, if you do have this, it'll usually be on both sides of the body, and make sure you tell your doctor about it because what they'll do is probably decrease the dose of the statin that you're on, or maybe just try putting you on a different statin, because just because it happens with one statin does not mean that it's going to happen with every statin that's out there. And there are several different ones that they can try you on until you find one that works best for you. So I was telling them that statins are first-line treatment for high cholesterol and why, and the side effects that it can have. Can you tell them a little bit more about which statin is your go-to statin and why, and maybe the difference in a high intensity and a lower intensity statin?
So statins are a first-line treatment for people with high cholesterol if we're going to go ahead and start people on medication. We like to say our first line of treatment is diet and exercise. I will say that from the prescribing side, because ultimately we'd like to correct the problem within your lifestyle that's causing you to develop plaque instead of just keeping it from forming. So we actually start with omega-3 fatty acids, and even if you're on a statin, it's very, very beneficial to take an omega-3 fatty acid supplement to help increase your HDL, your good cholesterol, and also keep you from developing plaque. But if diet and exercise and the omega-3 fatty acids don't work, then we do start with a low to moderate intensity statin, just depending on what comorbidities the person has. So, like I said, if they have cardiovascular disease, if they have diabetes, we're probably going to have to go with something more moderate, even to start with, because they're probably going to have a higher cholesterol level. But in general, we start with atorvastatin or Lipitor. It's probably the most commonly prescribed in the country. It comes, we start at the 20 milligram dose. That's the lowest dose that we prescribe. And that's considered a low intensity statin, but it can also fall into the moderate intensity statin in certain insurance company groups. So I guess that's a low to moderate. And we use that one because we find that it has the least amount of side effects as far as muscle pains. We also find that insurance covers it really well. And our patients seem to do really well on it. For patients that are not controlled on atorvastatin, then our next step usually is to change to the simvastatin, which is a much more potent drug, in my opinion. We will go to the simvastatin 40 or the 80, depending. Simvastatin, though, is known more for those muscle cramps that you're talking about than the atorvastatin. Some people have such bad muscle cramps that we can't keep them on a statin at all. Right. And then we have to look at things like, Zetia, which doesn't, it's technically still, in insurance groups, it's still considered to meet the quota for a statin, but it's a totally different type of drug, and it doesn't seem to cause those same muscle cramps, but it's also not quite as effective. So, again, the low intensity to moderate intensity is going to be anybody who just has pure mixed hyperlipidemia, or someone who has mixed hyperlipidemia and maybe some well-controlled diabetes. The moderate intensity is going to be anybody who has true diabetes that's not well-controlled, and or a uncontrolled cholesterol level even on our low intensity statin. And our high intensity are going to be people who have had strokes in the past, heart attacks in the past, or who have cardiovascular disease with peripheral vascular disease and diabetes and several other risk factors that make them very, very, very high chance that they're going to have a heart attack or stroke if they haven't already had one.
Patients often come in asking for coenzyme Q10 to help with these muscle cramps that they're having. Do y'all normally tell your patients that, or do you adjust their dose first, or what's y'all's first step if they are having these muscle pains?
Well, CoQ10 or coenzyme Q10, however you hear it colloquially, is over the counter. So we don't necessarily discourage patients from taking it, but it's not something that we prescribe. Right. If it helps you, then absolutely take it. It's not going to hurt anything. But I'm not sure how effective it is, because we do have a lot of patients that come to us and they've tried it and they haven't seen the results that they were hoping for. If a patient comes in and they're telling us that they're having muscle cramps and they're uncomfortable, of course, we're going to see what we can do to fix that while still controlling their cholesterol. So as a first line of defense, we're going to look at your medication list and see, okay, have we tried any other statin? Is there something else we can try that maybe you would tolerate better? And if the answer is, well, no, we haven't tried anything else, well, that's our first line of defense. Try another statin. If we've tried all the statins and you're still having, muscle cramps, then we have to start looking at how seriously does this person need the statin. If you're on a high-level statin, high-intensity statin, you're on, pravastatin 80, or you're on simvastatin 80, and you still have a cholesterol of 260, you're at high risk for a heart attack or stroke. We can't take you off of cholesterol medicine. We have to be able to control that to keep you from having a stroke. But we also don't want you hurting. So then we have to start looking at other causes of muscle cramps. Could you maybe have something off in your magnesium levels, which is a common cause of cramps. So we'll check magnesium levels and maybe start someone on magnesium oxide, which can often fix the cramps. It could also be because of low potassium, so we'll check that. We start looking for other causes. If we can't find any other causes as to why somebody may be cramping, and we also don't have the option to take them off the statin, then it becomes patient's choice, which is no doctor's favorite thing to say. Because, I mean, obviously, we don't want to cause someone daily pain, but we also don't want to cause them a heart attack or stroke. And so at that point, we have to say,
it's up to you.
It's totally up to you. But if you are having cramps and you're on a high-intensity statin and you still have high cholesterol, you might want to start looking at, could there be other causes for your cramps? Maybe it is the statin, but maybe it's something else. And then you could stay on your cholesterol medicine and control the cramps at the same time. That would be my suggestion.
Now, there is a risk of something called rhabdomyolysis, which is actually the breaking down of the muscles in the body. This is rare, but I think that people who are on statins need to know that this is something that could happen, and they need to know what to look for. That's very important. So, usually in a statin, people will have just a little bit of muscle pain and soreness. No, this will be excruciating muscle pain and cramping, and also you'll know because your urine will be dark in color. If this happens, tell your doctor right away. They will stop the medication immediately, and they will probably send you to the hospital, because just stopping the medication will not make it go away. You will need additional treatment to get this fixed. Cholesterol is produced in the liver and the body, so this is where statins do their work. So with that being said, liver toxicity is another risk of statins, which is rare. But what you need to look for is a loss of appetite, abdominal pain, jaundiced skin, which just means that your skin and your eyes may turn a yellowish color, and unusual fatigue. Now, what you'll do is you'll need to tell your doctor about this, and they'll probably just reduce the dose of your statin that you're currently taking, or they'll try you on another statin that may not cause these same side effects for you. The cholesterol in our body is made at night while we're sleeping, so usually you'll see that on your statin, it will be directed for you to take it at bedtime. Now, there are 3 statins that have to be taken at bedtime no matter what, and that is fluvastatin, lovastatin, and simvastatin. And the reason for these 3 is because they have the shortest action potential of all the statins out there. So we need those to be working their best while we're asleep and the cholesterol in our body is being produced. Now, usually with the other statins, your doctor will still tell you to take it at bedtime, but really you can take them at any point throughout the day because they're going to work for a longer period of time. So I was talking to them about how there are 3 statins that are required to be taken at bedtime: fluvastatin, lovastatin, and simvastatin. But other statins are also prescribed to be taken at bedtime even though they don't have to. I know y'all said y'all do atorvastatin the most, and y'all put that as taken at bedtime for your patients, right?
Mm-hmm.
Can you explain to them why you do that even though it's not required?
I think there are several reasons why people do that. One, it's just common practice in the medical community. Instead of saying, well, this one has to be taken at bedtime, this one doesn't have to be taken at bedtime. It's just general practice that all cholesterol meds are generally prescribed to be taken at night. But that's actually beneficial because if it does cause what we're talking about, some of the mild muscle cramps or, just discomfort in people, if they're sleeping, they're less likely to notice that.
Right.
The other thing is we have several patients, I would say most of our patients are on several medications, oftentimes a lot of medications. And a lot of these medications need to be taken in the morning or before they start their day so that they can be effective throughout the day. So if we add cholesterol medicine to that in the morning, it doesn't give them any additional benefit than having taken it the night before. Mm-hmm. And sometimes it can interact with other medications that they really need to work during the day. So for us, it's just best to prescribe them all at night, and that's what we generally do. And I think that's pretty common throughout the country that most cholesterol medicines are just prescribed at night, whether they have to be or not.
That's what we see usually. Grapefruit juice does not have to be avoided in all statin drugs, only atorvastatin, lovastatin, and simvastatin, because what grapefruit juice does is it blocks this enzyme in the body from breaking down these 3 statins. And the danger in that is that if the body isn't breaking down these drugs, we end up with an accumulation of this statin in our bodies, and that can cause more of those side effects that we were talking about, like the liver toxicity and the muscle pains and possibly the rhabdomyolysis. So we really want to be careful with that. But the grapefruit juice does not have to be avoided in any of the other statins that are out there. I was telling them that grapefruit juice does not have to be avoided in all statins, just atorvastatin, lovastatin, and simvastatin. Do y'all tell all of your patients to stay away from grapefruit juice, or do you say it only to those three? Because I know you said atorvastatin is y'all's most prescribed.
Yeah, so like I said, 90% of our patients are on atorvastatin, and if they're on something else, then maybe we wouldn't. But I also said that in our patient pool, and I don't know if this is true for everyone, most of our patients that are on a statin are also diabetic. So we actually try to encourage patients to stay away from juice in general, because while juice does have some vitamins and antioxidants that come from the fruit, it doesn't have the fiber that's in the fruit. It's just been juiced, and it's mostly sugar, which can wreak havoc on triglycerides, which is part of your lipid profile, and then also on your blood sugar. So in general, we try to just say stay away from fruit juices as much as possible. If you are going to have one, avoid the grapefruit juice, and also don't have more than that 1 8-ounce glass a day. That's it. That's all you need. Above and beyond that, water, water, water. Water helps with muscle cramps. So if you are experiencing cramps from your statin, you need more water. It also helps with hydration, of course, and then flushing your system, helping to move things out. So in general, people should really not just avoid grapefruit juice, but avoid all juices. And if you are going to drink it,
A little bit.
just a little bit. It doesn't provide the same nutritional benefit that the fruit itself does. So
Statins are not able to be used in pregnancy. There were some human studies done, and there was a risk of fetal harm. Now, there are no human studies done on breastfeeding, but they do recommend that you try alternative treatments before resorting to a statin due to the possible risk that it could be excreted into the breast milk and cause harm to the baby. That's it for this video, guys. Thank you for watching, and thank you again for Heather coming in and helping with any questions our viewers may have.
thank you for having me.
And this was kind of a hard video to do because I was talking about a class of medications instead of just one medication in particular. So I couldn't really hit on each statin for y'all. So if there is a certain statin that you're on and you want to know specifics like its drug interactions or its food interactions, make sure you drop that down in the comments below, and I'll be sure to answer any questions that y'all have about that. And again, if there's any particular medication you want to see a video over, drop that down in the comments as well, and I'd love to do a video over it for y'all. And make sure, as always, you subscribe to my channel. Thanks. Bye.